mean, and I'll say this many times, is the vertical transmission of syphilis from the mother to the infant during pregnancy or at the time of transmission. Now, when we talk about sexually transmitted infections, there are many, but it's important to note that most of them are vertically transmitted, and that includes HIV, syphilis, hepatitis B, hepatitis C, chlamydia, gonorrhea, trichomoniasis. There are many. So when we talk about syphilis, we don't want to forget that in the background of the risk of syphilis is also pregnancy, because pregnancy is sexually transmitted. Sometimes we forget that, but we must remember that persons that have unprotected sex may have the risk of being pregnant or making their sexual partner pregnant and increasing the risk or having the level risk of passing on an STD or an STI as well. So in the background, we don't want to think only of syphilis, but we also want to think about the other infections that can be transmitted sexually and vertically. And sometimes we call that syndemic. In the United States, we have a syndemic of certain infectious diseases alongside a background of, I'd say, disparities, social situations, and behavioral decisions that put people at increase of sexually transmitted infections. And in addition to that, we have a background of substance use disorder across the nation, in urban and in rural areas. There are populations that we consider to be vulnerable to these different types of infectious diseases, as well as substance use disorder, and they include gay, lesbian, transgender, queer, questioning populations, LGBTQ, and we also include our adolescents and pregnant people in that at-risk group. As always, we also consider minority populations and those that are incarcerated to be at risk due to other factors that put them at risk for being able to access health care. The biggest issue that we're here today to talk about is congenital syphilis, and that is the vertical transmission of syphilis from mother to infant. And as we were hearing about the situation in Montana, it is the second leading cause of stillbirth in the world, with malaria being the first. So we have the issue of congenital syphilis as our leading cause of preventable infectious stillbirth in the United States. And the rates, not just in Montana, but in the rest of the United States, are higher than they have been in the last 2 to 3 decades. So it is something that we need to address. We need to address it fast, and it probably will come at a high cost and a high time period for bringing these rates down. Opioids are in the background in addition to methamphetamines in most of our states and in Montana as well. And what it means is that we need to develop a holistic approach to prevention, but also bringing patients in for treatment. Because we know that in some situations, in some states, in some counties, in some parts of the United States, and in some parts of Montana, people are penalized for their use of substances, and that may keep them from coming into the medical care system. And that may delay their treatment or simply keep them from being treated at all. And that may also keep their partners from being treated. And if that partner happens to be a pregnant person, then that infant does not have the chance to be prevented from birth with syphilis, for example. All right, so what I want to start with are the clinical recommendations here that we are considering best practices that were put in place, recommended by the Chief Medical Officer, Dr. Loretta Christensen, for the Indian Health Service. And when she puts forth recommendations, we don't really consider them recommendations, we consider those direct orders for IHS facilities, with the idea that 638 facilities might follow suit, given the need to practice what's considered a gold standard. And in October of 2022, Dr. Christensen put in these 5 mandates. Let's call them mandates. You can say they're recommendations, but really they are her expectations for implementation at IHS facilities. The first, and this is a first nationally for any clinical health entity, is that everyone between the ages of 13 to 64 should be screened for syphilis annually. That offers some benefits. Of course, we're looking for undiagnosed cases, but when we talk about staging of syphilis, this also offers the benefit of having a negative test in someone's medical record if they are negative, and then if they turn positive later, it helps you to gauge or to stage that diagnosis of syphilis. We'll talk about that in a minute. Everyone between the ages of 13 to 64. You might recognize this as being similar to the HIV screening or hepatitis C screening. So now we have syphilis alongside that, and as a syndemic approach to recognizing that all of these diseases transmitted together or are related to the same type of transmission. All right, so in addition to that, she wants to address this endemic by adopting a syndemic bundle. And when we say bundle, some of you who work with IHS and our PMS, you may remember that within our systems, we have the ability to create lab order bundles where you click one box and the patient will get tested for multiple conditions. Sometimes we use that for prenatal care labs. This is specifically for the syndemic, and you can see that this is batching STI, HIV, and viral hepatitis testing all at once and all with one test. And you can see that also she recommends that we do test for chlamydia and gonorrhea using the appropriate sampling techniques based on the patient's mode or exposure route. That means a urine for patients who have urethral exposure, a rectal swab for those exposed in the rectal area, vaginal swab, and of course an oral swab for oral exposure. And then screening for hepatitis B, and not forgetting that pregnancy is sexually transmitted. Pregnancy is sexually transmitted, so you want to make sure that you don't leave off a pregnancy test for people who can become pregnant. All right? And express testing is another recommendation from the CMO, and that is that any patient should be able to simply walk through the door of a clinical facility with an IHS and ask for a test. That can be an express test. You can come out and say, I want an STI test, but you shouldn't have to wait for an appointment. You shouldn't have to wait for somebody to schedule you into a primary care clinic or establish a primary care provider for you. You should simply be able to ask for the test. And that on-demand testing can save time for the patient and the providers. It can also reduce the time a provider, or the number of patients a provider needs to see. And it also can increase the number of people that get tested. So that's express testing. And then there is the recommendation to screen outside of medical facilities for these infectious diseases now, particularly in this time of an outbreak. So outside of the clinical facility, we have opportunities within corrections, schools, community events, and other situations such as worker physicals and school physicals where people may be at risk and have the opportunity to be tested. And then finally, and very innovatively, she has called for the field-delivered treatment of syphilis using injections of benzathine penicillin. And what that means is that instead of requiring someone who may not have transportation or childcare or have access to the ability to get to clinic, we can take the penicillin to them. Now we have protocols for that, and we also can share those as well. So these are important to remember as the Chief Medical Officer's recommendations. One of the ironies about this syphilis outbreaks across the United States is that we are running out of penicillin. And around February or March of 2023, the US and the FDA, in collaboration with Pfizer, announced the shortages of benzathine penicillin, the only recommended treatment for syphilis. There is an alternative drug, as Dr. Kukshamanic just mentioned. We can use doxycycline, but it is not the optimal recommended drug. For everyone, we want to give penicillin, and we must give penicillin for pregnant women. The alternative, doxycycline, is not as good, and that is the reason is because you have to take multiple doses over many days, and we know that sometimes patients don't do that. We do have a shortage, we have alternative drugs for that, but please remember that Pfizer has now announced that they will not recover the full demand for benzathine penicillin until the second quarter of 2024. So we're looking at a full year from now before we will have the stock that we currently need for the treatment of syphilis. We have 2 virtual trainings that are coming up. This is a substance use disorder training, and this one is very much linked, as we discussed already, with the syphilis outbreak. And then we also have another syphilis training coming up in July. And so these registrations can be accessed at this QR code, and we'll make sure that we have this available for you at a later time so that you can access that. All right, so let's go into some of the epidemiologic and clinical aspects. So when we talk about the clinical aspects of syphilis, I'm going to show graphic images of what these lesions look like and what the stages of syphilis are. And we do this so that you can recognize, if you are a clinician, what someone presents to you with symptoms. But what I want you to remember now is not that there's going to be symptoms graphically shown on the screen, but that most patients don't know they have syphilis because they don't see the symptoms. They see the symptoms, but they don't acknowledge that that might be the risk or the infection that they have, Or they see the symptoms, they go to the doctor, but the medical provider doesn't actually recognize that as syphilis. So we have a lot of work to do to educate our communities, to educate our medical providers, and to make sure that this awareness leads to healthcare access. When I mean healthcare access, I mean testing and appropriate treatment. So let's go ahead and take a look at some of these. As I mentioned before, I'm in Arizona. I've been assigned to Arizona off and on for over 15 years at the state, the county, and tribal levels. And I work in the Phoenix Indian Medical Center. And Arizona now holds the highest ranking for congenital syphilis in the United States. And that high ranking is in part due to the high numbers and high rates of congenital syphilis among our American Indian populations. In similar situation is New Mexico, our border state, and states for which some of our tribes cross into. But then also notice that states that now are above the U.S. total are some of the states for which we have tribal populations that are well known to us. Oklahoma, Cherokee Nations, South Dakota, and now Montana has surpassed or passed higher than the national average. All right, let's talk about syphilis. It's a bacteria, it's not a virus. And for bacteria, we can treat these with antibiotics. Oops, a little bit sensitive. So hang on with me here just for a second. Let's go back. It occurs in stages, and the stages are important because they have different symptoms, but also because you treat them differently. And when I say treat them differently, it's important to remember, again, we have a shortage of penicillin. We don't have enough penicillin to treat everyone with the later stages. And for that reason, it's going to be better if we diagnose patients in earlier stages of syphilis, because the earlier stages of syphilis only require one injection of benzamine penicillin. So the 4 stages which we're going to talk about are primary, secondary stage, early, less than a year, unknown duration, or late, more than a year. And when I say a year, less than or more than, what I mean is since you were exposed and infected with syphilis. And so that takes a little bit of detective work. It takes someone to take a good history from the patient and for them to trust you enough to tell you when they think they were exposed and to potentially tell you who their sexual partner is, because if you don't treat the sexual partner, guess what happens to your patient after you give them penicillin? They're going to get reinfected. So this part is the critical link to stopping an outbreak, are finding cases and finding their sexual partners and getting them treated. So this is really important, and that's why these stages are important as well, because there are interview periods for which you know the patient was likely infected based on their current stage. All right, we've seen this before, and just to show you the counties that are affected across the United States. Historically, you are aware that in the Southeast we've had a lot of syphilis for many years, and I think that in the Southwest we are also experiencing that, and this is Arizona, the northern area. Tribal lands are heavily affected. California, Oregon, and Washington are having a lot more or higher rates as well. And what is important to remember also is there's a transition that is occurring, and that is what we call a male-female ratio. Whereas before, you probably are aware that syphilis occurred more commonly among men, and those were sometimes reported as men who have sex with men. The difference now is that the case rates are going up faster, and we are seeing many more women infected with syphilis, and that, of course, results in infants born with syphilis when these women are not detected during pregnancy and when treatment is not given early enough. We're going to skip through this, but again, adult syphilis has increased dramatically over the last decade. And we also know that among adult syphilis cases, for the first time now, American Indians and Alaska Natives have the highest rates of syphilis in the United States. Keep in mind that CDC is about a couple years behind just for the processes it takes to get these data out, but we do expect this rate among American Indians to be a little bit higher for 2022. The stages of syphilis look linear here, and we're going to talk about each of these stages with photos. It's important to remember that immediately after exposure, your test may be negative, and up to 90 days it takes for someone to develop a primary stage lesion. Primary stage is associated with a syphilis chancre at the site of exposure. The bacteria crosses the skin barrier. So wherever you have touched someone, a lesion on someone else, you will develop a lesion roughly at that same spot. So if you've had oral sex, if you've had anal sex, vaginal sex, or you have been exposed through some other means of contact with a syphilis lesion, at that spot, you are going to develop a primary lesion, and that's the primary stage. The primary stage is not the first time you got syphilis. The primary stage means you have a lesion, and we'll talk about that. If you don't get treated, that'll go away. And a lot of patients are reassured, medical providers can be reassured, whatever that was is gone now, everything's okay. It's not okay. You develop the secondary stage, you progress to the secondary stage, which is heralded by a lot of different mimicking symptoms. Most commonly a rash. The rash can be on the palms and soles of the feet. We'll look at that. If then you don't get diagnosed and you don't get treatment, all those symptoms will go away, but yet you will progress into the latent stages. And thankfully, you are less infectious to your partners, but you are not necessarily less infectious to your infants if you are a person who can become pregnant. But we still know that the bacteria is disseminating in your body. And then after 1 year, since your original infection, we call that latent, and that's greater than a year. And again, the bacteria has disseminated, and there is risk for tertiary syphilis. We don't see that very often. What I'd like for you to remember is that a lot of these cases now in the U.S. are presenting with neurosyphilis. And what I mean by that is kind of the meningitis type response or infection in the fluid around the brain, and also stroke. Patients who have syphilis can have a stroke. In addition, and more commonly now, they are going to their ophthalmologist and they're saying, "Doc, I can't see very well, there's a lot of flashing lights around," and the ophthalmologist will diagnose them with uveitis, but the ophthalmologist won't consider syphilis. And so this is another situation where the diagnosis can be missed, where a patient has syphilis. And also, it goes to the cranial nerves and can cause otic syphilis or auditory syphilis, and that's where it invades. It causes deafness and also ringing of the ears. Patients will present with ringing of the ears. So here's the lesion. The reason it's oftentimes missed is because it's inside the cavity of the mucous membranes of the mouth, vaginal canal, rectal area, penile area where it's not noticed, but it's painless. This is another reason. People don't know they have it because it doesn't cause pain. It can be anywhere, and usually it's a single lesion, but it can be multiple, and so that's important to remember. And the other thing to remember is that in a situation where your patient has been screened, let's say they came in or they were tested at a community event and their blood test came back positive for syphilis. You want to look for a lesion. So you want to look for the lesions. And what I mean by that is if you are able to find this, your patient only needs 1 shot of penicillin and they're cured. But if you just get a positive blood result for syphilis, it's very difficult sometimes to figure out when your patient was infected. And if you don't look for symptoms, you will not be able to stage them as a primary stage or a secondary stage. So we want to look for the lesions. We want to look for lesions for syphilis so that we can rule in the primary or secondary stage and give them 1 injection or 1 treatment of syphilis, 1 treatment of benzocaine penicillin. Okay, if you don't get diagnosed and treated with primary stage, you can develop secondary symptoms. I'm going to stop here and say one more time. Most patients don't know that they have syphilis. So I'm showing you the symptoms, but many times they don't recognize the symptoms. Providers don't recognize the symptoms, and the diagnosis can be missed. So if a patient comes in and they don't have symptoms, it does not mean that they don't have syphilis. And that's why now, in this time of an outbreak, we are saying, test everyone. Okay, back to secondary syphilis. Syphilis is the great imitator, the great masquerader. A lot of the symptoms can look like other diagnoses. So when the patient comes in, it's like, "Oh, doc, you know what, I've got this rash, but my mom has eczema, so this is probably just eczema." Don't forget that we're in the midst of a syphilis outbreak, and this is probably syphilis. Palms of the hands, soles of the feet, this is rarely seen in other diseases when you have lesions here. Some of these you can have tick-borne diseases or other infectious diseases, but they are not necessarily in Montana. So when you see this, think syphilis. This one particularly, think syphilis. Here are mucous membrane patches or mucous patches in the mouth. You can have wart-like lesions in the genital area called condyloma lata, and you can have the hair loss of the eyebrows on one side, both sides, in the beard. You can have hair loss in the pubic area, and most definitely on the scalp. And this is syphilis. You want to make sure you test patients, but if they give you a history, you may want to go ahead and give them penicillin while you're waiting for that test result to come back. Okay, so here's where your history becomes much more important. Your patient has a positive blood test, but they don't have any symptoms. You've done a thorough physical exam, you haven't found anything, so maybe you need to talk to your patient and say, hey, are you aware of any of your sexual partners being diagnosed with syphilis? They say no. Then you say, okay, well, when was the last time you had sex? And ask the patient who their sexual partner is. And when I say who, I want to know the first name, the last name, the age, and where the patient, how the patient can be contacted. Because we are now in a situation where we must help the public health programs to find the sexual contacts and bring them in for diagnosis and treatment. Because it's in this specific situation of high numbers of cases, there aren't enough public health investigators to go out and find these sexual partners. And then you can also ask patients, sometimes adolescents, it would have been their first sexual encounter. And so you might be able to determine that this has been a less than 12-month window simply by understanding what their sexual activity is. And then again, if you have a prior negative test in the last year, then you know that's an early latent case. So a lot of detective work in making sure you get a good history. If you're not able to rule in early syphilis, either by symptoms or by history, then we're stuck with this unknown duration or latent stage. Why is that something to remember? How many doses of benzodiazepine penicillin? That's going to take 3 doses. And what's the interval between those? 1 week. That gives your patient time to get all the way to Cuba with that first painful dose, and you're never going to find them again because they don't want to come back after that first injection. They're painful. It's like getting a tetanus shot. It stays with you. The gift that keeps giving. Okay, so then you have 3 shots here, and they're spaced by a week. And if this patient is pregnant, she comes in on day 10 from between that first and second injection. You've got to start over. It's a hard and fast 7 to 9 days for pregnant women. We give a little leeway if you're not pregnant, 10 to 14 days, but if you're pregnant, you need to get those doses in less than 9 days. Absolutely. All right, neurologic manifestations can occur at any stage. This is the situation where patients can go blind and you can give them penicillin later and they are still going to be blind. This is a very invasive bacteria, and these are some of the manifestations of the neurologic invasion with the spirochete treponema pallidum. So I'll leave this for you guys to take a look at what's important to remember about all of these stages, and we don't see much about tertiary syphilis anymore. But it's important to remember that penicillin is the treatment for all of these, and when you get to the late stages of syphilis, you need to admit someone, or neurologic stages, you need to admit them for IV therapy.
Do you want to just define tertiary?
Yes, tertiary syphilis. Tertiary syphilis are the late stages of syphilis that we really don't see anymore. So these are the ones where we talk about Al Capone, Hitler, people who kind of develop dementia and sometimes psychological manifestations. But it also can be used for the invasion of the heart, the bones, the liver, the spleen, and other structures that are related to the neurologic system. For the most part, we don't see a lot of that anymore because we do have good diagnostics and good treatments. And a lot of the antibiotics that we use also partially treat syphilis. So we don't see this, thankfully, but a lot of times as part of a dementia workup in elderly populations, you will generally see a syphilis test as part of that. So in this situation now where you're doing pre-screening, you may actually uncover some late-stage syphilis. Okay. The diagnosis of syphilis cannot be determined by a lab test. The lab test is going to tell you that the patient has syphilis, but the staging is based on the presence of symptoms, the history of symptoms occurring in less than 12 months, and the history of someone's sexual exposure to an infected partner. However, the diagnosis does rely on someone having a positive test. And the way that we test for syphilis is we do one test to screen. If that test is positive, we do a second test to confirm. So screen with one test, confirm with the second test. You don't get to decide which tests are going to be used. That's already decided by your clinical facility. They have an algorithm in place, and when you order syphilis testing, they are going to put that blood into the sequence of testing that is already in place. So in the traditional sense, we use a non-treponemal test to start. If that's positive, then we will do a treponemal test. So the RPR is the one that we use most commonly in the United States, and the TPPA is the confirmatory treponemal test. For the purposes of automation, a lot of the larger labs, practically all of the large labs like LabCorp, Sonora Quest, or Quest, and other large labs for which we have send-outs, they are doing a reverse sequence algorithm where they do the treponemal test first, and that is then confirmed with an RPR. The RPR is important to remember because it comes in a titer. And the titer can be 1 to 1, 1 to 2, 1 to 4, 1 to 8, 1 to 16, 1 to 32, can go all the way up to 5,000. And that is an important thing to get for each of your patients you diagnose with syphilis, because you want to see that titer decline when the patient is treated. It can also help you understand if the patient has become reinfected. So penicillin, penicillin, penicillin. One dose for primary, secondary, early, latent. 3 injections for late latent or unknown duration, which you don't know when the patient was diagnosed. If you have a patient who has neurosyphilis, optic syphilis, or otic syphilis, they need to be hospitalized for IV penicillin. Okay, now penicillin allergy. Excellent question earlier today. Thank you so much for that question. When patients have a penicillin allergy, it's important to determine if they actually have a penicillin allergy, meaning do they have anaphylaxis, or is it something that maybe they were given as a child when they had some nausea and vomiting after they took amoxicillin, and it's been in their medical record for the last 3 decades, and now that they've been diagnosed for syphilis, you notice that they have penicillin allergy in their chart. Penicillin allergy is rare. True penicillin allergy is rare. So if there's the opportunity to use skin testing to determine if they actually have penicillin allergy, that is very important. And the allergies wane over time. So even though they may have had an allergy as a child, they may not still have that same allergy. If a patient truly has a penicillin allergy, true allergy with anaphylaxis, they can get the alternative drug doxycycline. That's an oral drug that they have to take twice a day, and they have to take it for at least 14 days for early syphilis and 28 days if they have late latent syphilis. So it's not the ideal drug. And for pregnant women, they must get penicillin. And if they are allergic, they have to be desensitized. And desensitization is where they give you very small doses of oral penicillin. They give you one small dose, and then they watch. They give you another slightly larger dose, and then they watch. And then another slightly larger dose, etc., over the course of about 4 hours. And by dampening the immune response, you are then able to receive a full dose of benzathine penicillin. So this is a very, very important protocol that is used for pregnant women, especially with actual penicillin allergy. Okay, so let's review congenital syphilis. I'm going to show now some graphic pictures of infants born with congenital syphilis. But I want to talk a little bit about the epidemiology at the national level first, and let you know that these high rates of congenital syphilis are matched with high rates of syphilis now in women, which we had not seen before. So let's go back one slide. But just we haven't really seen high rates of syphilis in women. Just 10 years ago, there were actually states, including Alaska and Hawaii, that had no syphilis in women. And over the last 10 years, we have now blanketed the United States with high rates of syphilis among women of childbearing age. And this is data from 2021, but you will know that these 2 states will be high in 2022. So we have the situation of high risk of congenital syphilis, and then, of course, as I was showing you before, the highest rates of congenital syphilis are among American Indian Alaska Natives. These are 2021 data. And what we know is that these 102 cases of congenital syphilis or infant syphilis represent 1 out of every 260 births to American Indian women. So the rate is high of the infants with congenital syphilis, and the rate of syphilis-affected pregnancies is also very high. Okay, what does congenital syphilis cause? We talked about it before. Second leading cause of stillbirth, that's indicated by a very thin blue line, dark blue line. It's not the majority of outcomes, which is good. The second thing to remember is that after birth, the infant can experience death within 48 to 72 hours due to just catastrophic circulatory collapse, profound anemia. It's not something that we can reverse with even the highest levels of medicine. Many of the infants can be born alive, but they have signs and symptoms. I'll show you those. And then we have a large proportion of the cases also that are born without symptoms, but for whom we know that the mother was not treated adequately. And so they are considered congenital syphilis cases. Okay, what's the number one reason for the diagnosis of congenital syphilis among all women giving birth to infants with syphilis? It's actually not getting prenatal care or attending prenatal care too late. And we know that this is a risk factor in Montana. We know that this is a risk factor among American Indian and rural tribes. And we also know that this is the reason for the entire United States for the delivery of infants with congenital syphilis. It's not different because we're in Montana. It's not different because it's high rates among American Indian Alaska Natives. This is the reason across the U.S. And the second highest reason is even if the mom is diagnosed, the adequate treatment that she requires is not given in time. And why could that be? I think Dr. Cookshaman mentioned it earlier, and that is that when you are diagnosed with latent stage syphilis, or we don't know when you acquired syphilis, that gives you 3 injections spaced by 1 week apart. And if you don't get all those injections, well, then your infant has congenital syphilis. So again, we want to stage early syphilis. And early syphilis is primary stage, which is the chancre or lesion, secondary stage, which is the rash, and the other symptoms we showed, and then early latent syphilis is when you acquire syphilis less than 1 year. It gives you 1 shot, even for pregnant women, 1 treatment with benzocaine penicillin, and that's it. Okay, so here we go. This is the congenital syphilis case rate by race ethnicity, and for the first time we've seen that. Not for the first time being the highest race ethnicity, that started in 2019, but you can see that during the COVID years, this has really taken off, and now American Indian Alaska Native infants have the highest rates of congenital syphilis in the United States. So what does congenital syphilis look like when the infant is very much affected, born alive, but has the signs and symptoms of congenital syphilis? Well, as an adult, the syphilis organism goes to the skin and mucous membranes of the infant. So the infant can have mucus patches in their mouth, they can have the skin manifestations on the palms and soles of their feet, they can have facial lesions, and this can be mistaken for something else. So it's important to remember, again, that medical providers need to be educated as to what congenital syphilis looks like, particularly because a lot of women now are coming in for their first prenatal visit when? At delivery. So that syphilis test result may not be back before the baby is born. So we need to make sure that our medical providers know what this looks like, so that they will have suspicion before that syphilis test returns from the mother who has never been tested yet, has not yet been tested. Okay, enlarged liver and spleen, this infant has sequestration, probably profound anemia, is born alive, but again, is very critically ill. This one has thick discharge from the nose that has the bacteria, the Treponema pallidum, and you can see this angular lesions here at the corners of the mouth. This infant has long bone abnormalities where the organism invades the outside corticum of the bone and causes decreased opacification in the bone cavity there. So these are some of the manifestations of congenital syphilis. and others are laboratory derived, such as meningitis and anemia. When infants are born generally exposed or concerned for exposure to syphilis, we do recommend that they get a lumbar puncture and that the fluid from around the spine and brain is tested with protein, cell count, and a VPRL. That's a little bit more detailed than perhaps you need to know, but it is important to remember that we do recommend certain clinical workups for infants born with exposure to syphilis. Okay, the diagnosis can be a little challenging, but please remember that the diagnosis of syphilis in an infant rests almost 100% on the diagnosis and treatment in the mother. The mother has been diagnosed and treated appropriately, and in time, that can be a case of syphilis prevented in the infant. Go ahead.
If a mother was diagnosed and treated appropriately and her infant had a negative RPR at birth, do they need to follow RPR?
Yeah, okay, this is a good question. We do generally say
Can you repeat
that
the
if
question?
mother...
Can you repeat the question?
Yeah, okay, great. If the mom was treated adequately and in time for her stage of syphilis, and the baby had a negative RPR at delivery, do we consider that a case prevented? And the answer is yes. If the mom received adequate treatment based on the stage, and all the treatment was given or at least started greater than 30 days prior to delivery, we do consider that an averted or a prevented case of congenital syphilis. Excellent, yes. And there are successes. There are many successes. I know that we see the failures and we think that this is this is not something that we can't overcome, but we can. Because for every case of syphilis you see that has occurred, there is at least one that has been prevented, roughly. Yeah, roughly. Okay, let's keep going. For low-risk infants, sometimes we do give them one shot of benzene penicillin. But for infants with congenital syphilis, they need to be admitted. They need to be given at least 10 days of IV, continuous infusion, aqueous. All right, stillbirth. So we know that stillbirth is caused by syphilis, and we do have a criteria for case definition, and that is greater than 500 grams in weight, and also greater than 20 weeks gestation. But there is a lot of miscarriages that are due to syphilis as well. So you want to capture that in the history in childbearing women, and it is a reportable condition. As we heard from Dr. Kuchari on those things. Okay, so I want to ask for questions here, and then we're going to go in and we're going to talk about some of the challenges, and we're going to review a few outbreaks in some of the rural communities that have published their results. Do you have any questions on the clinical aspects? We